introduce the two speakers. Okay, hello everyone. Welcome. So I'm just going to introduce the two speakers. It'll be Dr. Raj Mahajan, and Dr. Christine LaRocca. So Dr. Mahajan is the president and CEO of the Chicago Internal Medicine Practice and Research and leads its affiliate groups of companies. He's the clinical associate professor at University of Illinois, clinical instructor at Rosalind Franklin School of Medicine, and also an attending physician at Loyola, and then the affiliated geriatrics fellowship program at Heinz VA Hospital. He's a section chief at geriatrics at Illinois Masonic Medical Center, and he's a fellow of the American College of Physicians and board certified in internal medicine and geriatric medicine. Dr. Mahajan is also a certified medical director, a certified physician advisor in the utilization review, healthcare quality management, and is certified in infection control and epidemiology. He serves on the several technical expert panels for the Centers of Medicare and Medicaid Services and National Quality Forum. Dr. Mahajan received his MBA with concentration in entrepreneurship and MPH in health policy administration from UIC. His areas of interest in research include antimicrobial stewardship, quality measures, health information exchange, and interoperability. During the COVID-19 pandemic, Dr. Mahajan advocated for on-site vaccination programs for most vulnerable seniors in congregate settings, and the CIMPAR became one of the largest mobile vaccinators for low-income senior housing and nursing homes in Chicagoland area. And Dr. Christine, she's a fellowship-trained, board-certified geriatrician. She received her medical degree from Vanderbilt University School of Medicine and completed an internal medicine residency and geriatric fellowship at the University of Colorado Health Sciences Center. She serves as the medical director for Telligen, a leader in population health management solutions and quality innovation network, quality improvement organization for states of Colorado, Illinois, Iowa, and Oklahoma. At Telligen, she provides clinical oversight and subject matter expertise for local and national contracts and subcontracts, including the Center for Medicare and Medicaid Services. During the COVID-19 pandemic, she is serving as a member of the Colorado Residential Care Strike Team and the Colorado Governor Expert Emergency Epidemic Response Committee Medical Advisory Group. So without further ado, the past, present, and future of antimicrobial stewardship.
Thank you so much. And I know sometimes it gets, those resumes and bios tend to be too long. So we're going to cut right into our encore presentation here. And again, I thank Dr. LaRocca here for joining us. Many of you have known me from doing this work with this summit for a while. And again, it's always a pleasure. And as I mentioned earlier, it's just makes me just gleam in pride and joy that our long-term care fraternity by far is the biggest group now that is attending these summits. And I am just blown away with everybody's deep involvement and participation. And with that, we will start today, and again, as you see from this morning's technical difficulties, we are not turning our videos on because of bandwidth or however platform limitations where things get a little slower. So we will try to turn cameras on at the end when we go into a Q&A session, and hopefully we can have a little more interactive discussion then. So we're going to talk about Dr. LaRocca LaRocca is going to talk about the future, and I am going to focus on a little bit of past and present as where we are in antimicrobial, antibiotic, stewardship, and post-acute long-term care. Neither Dr. LaRocca or myself have any significant disclosures. Christine, are you able to see the slides transition? Because that was also a problem earlier.
I see them just great. Thank you,
Okay,
Rob.
great, good. So that's why we stay in the presentation mode. So the past, why we are here, why we're talking about it, why it's so important. Just take a moment to look at that screen. Bunch of numbers there, but just the distillation of all of that is a few things. One is 70%. So 7 in 10 people living in nursing homes will get one course of systemic antibiotic during a year. So it's almost all of them, right? So, and over half of these antibiotics are either not needed or are wrong or are prescribed for longer duration than they should have been. Pretty stark, right? And some other things on prescribers and how it works, we see that 80% of antibiotics are prescribed by 20% of the prescribers. So again, a little skewed that way. So some of the things we'll discuss, they become important. This is fresh off the press when I say it's just coming out in the last couple of months. Again, CDC and some academic centers did a point prevalence as it on any given day, how many people in a nursing home are on antibiotics. So what they found that in any given day, 8.2% or 8.2 out of 100 people in a nursing home setting were on an antibiotic any given time. And again, no surprises here that 1/3 of that was for urinary tract infections, and similarly, 1/3 of them were broad spectrum, not narrow spectrum. So some, again, background on how it all started. I put some screenshots of some important things that have happened in the past. In 2014, there was a very large White House call. So to all the experts were put together by Obama administration, and it was really looking at some of the data of antibiotic use and this sense of urgency that we need to do something to combat the resistant bacteria that were especially in the long-term care setting. And in 2015, CDC published the first version of the core elements, which we will be discussing, and that will be my part as present of nursing home antibiotic stewardship. And then CMS in the mega rule SNF regulation in 2016 was very descriptive on regulation around antimicrobial stewardship, and in 2017 Joint Commission came up with the standards. Again, here it is. This is the present of where we are in nursing homes with antibiotic stewardship, antimicrobial stewardship, and those are the core elements. And it could be found on the document. Of course, most of you have seen it. If you have not, you can go to that link, and the whole 24-page document is available. A lot of changes have been made to it on practical approaches, but mainly the elements that are in the core are the leadership commitment, accountability, drug or pharmacy expertise, actions, tracking, reporting, and education. I speak that loudly and fast because this is a snapshot, but over the next 7 or 8 slides, I'll just go over that and pass it on to Dr. LaRocca there. So to me, the most important thing is leadership commitment, and the so in a private setting, the owners, the administrators, the investors, on the nonprofit setting, the board of directors, the executive directors, you have to have them realize not only what we do, but why we do it. And again, we go back to the real reason that we're not cutting down on antibiotic use. We're not stopping people. We are making sure that the antibiotic being used are appropriate and that we are not harming people by giving them either inappropriate antibiotics or duration that is longer. So making sure that we're doing the right thing, we're saving people, we're helping people, not harming them. So making sure that there is an official commitment from the leadership to this cause is very important. And with leadership comes leadership's decision to define the accountability. And again, we have to empower the leaders, the true leaders, when it comes to clinical topic like antibiotic stewardship. We talk about the medical director, we talk about the director of nursing, we talk about clinical pharmacists. So they are the experts. They are people who should be involved, and as leadership we have to empower them. Now we do get into a few details here about how to empower the program leaders, and also have some dedicated time. The Infection Advisory Committee of AMDA that I've been part of since its inception recommends that we should have the infection preventionist on about have 10 hours a week dedicated towards antibiotic stewardship activities. Now, some people think it's too much, some people think it's too little, but to be specific and not be gray. And, so something was put out there by the group of clinicians that are out there, and we can have discussion, debate, or powwow about this. And we know that overall infection prevention and FTEs and et cetera are very important. Sorry if people. Yes, and so that's really making the accountability on people who are in the leadership role. And here, one of the things that we can do is making sure our facility has a very, very succinct antibiotic stewardship policy. So here is a guide that, again, through the AMDA and the Society of Post-Acute Long-Term Care Medicine, publish a guideline or a guide to developing the policy for antibiotic stewardship, and a lot of authors here have been actually part, and we've been blessed to have them as our speakers. Dr. Ashraf, Elizabeth Frenzel, and Steve Sharon, we all have had, visited us with their and in the past for our Antimicrobial Stewardship Summit. So this is what it looks like. I also have a link to Nebraska's long-term care tool repository that also is a good place to go to get some of the help. And I know Dr. LaRocca is going to also help us with Telligen and their resources, but just another place to get some of the resources on, whether it's the antibiogram or some tracking tools, etc. So, and this is a sample policy that shows how we can show our commitment to antibiotic stewardship. Again, very, very, very important, is a crux of a strong program to have a stewardship committee or a team. And as we mentioned last time, there are some required people to go on that committee. There has to be a structure of that committee. It has to be a very, very structured meeting cadence on how often it meets and where they report into, and how it goes all the way up to the QAA committee, and so the leadership is aware of what's happening on antibiotic use. So if you look at that, again, infection preventionist is the key leader, and the champion medical director, consultant pharmacist, and director of nursing must be part of it. And then there are obviously resident council members, and if you can get them and CNAs to be part of it, is just so very important. And again, it should meet at least quarterly. We recommend monthly. Again, that will be up for discussion at the end. Very excited to have that discussion with all the leaders on in this meeting. So again, a stewardship committee should be tasked with some very specific tasks. It's here on your screen. Some of these things that are very important. And again, as people requested, these slides will be for you to have. So you can read through them. And so we should have antibiotic use protocols. We have to monitor antibiotic use, also look at the different resistance bugs that are being cultured, and also side effects like C. diff and other hospitalization, readmission, etc. Again, continued on to when it should be tracked, how often it should be tracked, things like that, and what items should be tracked that are right there. Some of the things that we talk about a lot is number of antibiotic starts, as in how many new antibiotics were started. And then there is some discussion about whether it was started in the hospital, started in the nursing home, etc., and days of therapy. So how many total days of antibiotics were used. And so those are the few things that we can start out with when we start a program. And then as we program matures, there can be much more complex indices that we can monitor. So again, some of the data that is required is up here. Antibiotic starts, and these are antibiotic use measures on days of therapy. And then we have process measures, as well as we have outcome measures. So, this is really going from very early and indicators of stewardship to outcome, which is really the good things that happen or the bad things that happen, which is really an outcome. And these are the things and data that can be tracked as part of your program. And so, as you mentioned, antibiotic starts or antibiotic use, all the way up to having resistance bacteria in the building, C. diff infections in the building are the things we can track. Again, this is antibiotic use summary that you can look at, and it summarizes, what antibiotics were used, when was started. Again, a good table that is also available in electronic format. Again, I give you a website where you can go, and I will be available for further questions and guide you through having some of these very robust tools that can track the antibiotic use. Again, so one of the elements of tracking and monitoring, these are some of the things that we do: C. diff infection, MRSA rates, CRE rates, and then that we do have antibiograms, etc., available. And again, at the end, when we have time, we will talk about antibiograms and how and when and where it should be published, and what else we can do if it is still something that people are having challenges in. We mentioned that several times since this morning now, that antibiotic use should be appropriate as to what we use and how we use it. And I know Dr. LaRocca will help us with that in her portion that comes up. Again, last couple of slides. Why data is important? I want everybody to just take a quick look at this screen. We have some data reported here. We have some antibiotic starts mentioned. We have some days of therapy mentioned. And now we have different infections and different antibiotics mentioned. So here, this particular facility has dug into some details, right? Where you had urinary tract infection treated 39 times, and then of that, 16 actually met the criteria to start antibiotic, and 23 did not. So look at that number. That gives you, the where we started, right? So we are reviewing every single antibiotic for the indication, and then I don't have to tell the people here that what are the different tools we use to decide whether the antibiotic was appropriate or not. So just look at that. So we look at this data. It is robust. It's colorful. It's pleasing to the eye. And if as a nursing home, you could have that with you as your baseline data. You can go from here to a place that's so beautiful, that still gives me, very, very, it's just the satisfaction, happiness I get when people actually have that data and can decipher the appropriate use, and then the actions you can do so you can have your performance improvement plan for appropriate antibiotic use. So again, there's some slides, or last slide, on antibiotic use, giving the feedback to people as to what antibiotics we have used, and it is very important that the physicians, the practitioners, are given peer comparison data, which again was discussed earlier, that we make sure that there is feedback given to all the practitioners. Education is very important. We educate the nurses. We educate the prescribing providers. We educate the families. We educate the residents, and again, very important to have resident council be part of that and have the buy-in as to why we do it. It is not denying access to care, but saving people from harm. Very, very important. So these are, again, a summary I have included for what we talked about. It was a rapid fire, and I do want to have Dr. LaRocca come in and take it on after this, and these are just the steps that we take for a strong program start and maintenance, and that we have. So truly, leadership support, again, accountability, have the expertise with the consultant pharmacy and hospital if we need infection prevention, infection control, infectious disease help from the neighboring hospitals. So those are the things that we discussed. This will be available in the slide deck. And with that, I will stop, take a breath, and as I said, we want to finish this in 40 minutes or less, and then leave good 15 to 20 minutes for discussion, because that's where it really is where the magic happens. Christine?
Thank you so much, Dr. Mahajan, and welcome to everyone who've joined us today. Again, I'm Christine LaRocca, and I wanted to make sure that I thanked and expressed my gratitude for the nursing homes and hospitals that have already joined with Telligen in our work as the Quality Improvement Organization. Across our 4 states, we're working with 1,300 nursing homes, and for our hospital quality improvement contract, we're working with over 190 hospitals in 15 states. So Dr. Mahajan has wonderfully covered the past and present, and I will now address actions that you may consider as you move into the future. I'll focus on antibiotic timeouts as an important practice, because it can help nursing homes optimize and monitor antibiotic use as part of your successful antibiotic stewardship program. And my goal is to keep it practical and pragmatic. So if we can go to the next slide, please. Thank you, Raj. You know, I love infographics like this, and I included it to highlight the number of helpful posters and infographics that are available on the CDC site as well as on Telligen's site. And you can download those, and maybe during the Q&A, we can talk about maybe some success that you've had with posting posters such as this in your homes. You can see that the CDC's 7 core elements are listed here, and I plan to hone in on just one of the elements, and that is action. Next slide, please. So the CDC recommends that we add antibiotic stewardship activities in a stepwise fashion. There's all of those clever sayings, you know, don't try to eat the elephant in one bite, don't boil the ocean. You get the gist. But stepwise is the way to go, especially considering the number of activities that nursing homes are currently involved in. The pandemic is not over, and all of your other responsibilities. So here's a list of activities that are important for your antibiotic stewardship program. I am going to focus on the first bullet, implementing policies on antibiotic prescribing and use. So if we can go to the next slide, please. Here are 2 examples of antibiotic prescribing activities that are important in your efforts to ensure that your antibiotic stewardship program is robust. And so one is documentation. Now, you know, you've all heard the saying, if you didn't document it, it didn't happen. And so what are the important elements of an antibiotic prescribing bundle? So here you see, and I like clever little ways to remember things, and one of them is the 5 R's of antibiotic stewardship. So documentation should include information to support that the resident is on the right drug. Are they on the right drug for the infection of concern? Are they on the right dose? And is it adjusted as needed to ensure optimal dosing for kidney function, for liver function, for obesity, and other considerations? Is the resident receiving the drug through the right route, such as by vein, IV, or by mouth, PO? And is the order for the right duration, including the start date, the end date, the planned days of therapy? There is literature suggests that there's a certain subsegment of prescribers that are quote unquote long prescribers. If they're going to write for an antibiotic, it's going to be for 10 to 14 days. And it's important when looking at your program if you can focus your improvement efforts perhaps on those prescribers. And then the right indication and the right treatment rationale. So is the antibiotic being prescribed for prophylaxis, meaning that it's for a procedure to prevent an infection? We're doing that a lot less often than we used to. Or for a therapeutic reason to treat an infection. And in the documentation, it's important to list the site of the known or suspected infection. Are we treating the urinary tract? Are we treating the lungs? Are we treating a wound? So this documentation is incredibly important for the performance of an antibiotic timeout. I'm going to show my hand that I am a big advocate of antibiotic timeouts, and I hope by the end of this talk you are too. I will take a little side note to say that we're currently dealing with the COVID-19 pandemic, but we also have a somewhat invisible pandemic going on, and that's the one of antibiotic resistance. I don't think any of us can imagine a day when a simple infection that we have nothing to treat it with, that we don't have an antibiotic that can treat that organism because it is so resistant. And we are facing this right now, that we have a real need for a call to action to prevent further antibiotic resistance. We used to feel safer prescribing an antibiotic, and I would support, thinking that we should feel a little less safe. We've already seen the ravages of C. diff and some other antibiotic-resistant organisms, and so that is my message today. But let's talk about performing an antibiotic timeout. Timeouts are specifically recommended by the CDC as a broad intervention to improve antibiotic use, and they allow you to just pause, reassess, reevaluate. Why is this patient on an antibiotic, and what are we treating? Why was it started in the first place? The timeout can serve as a prompt to gather all of the lab results that have come in and the current evidence about the resident's clinical status to determine whether the course of antibiotic therapy should continue, whether it should be changed, or whether it should be stopped altogether if an infection no longer appears likely. So let's go to the next slide, please. Here's the formal definition for an antibiotic timeout that you can see here. And an antibiotic timeout ideally is performed 48 to 72 hours after an antibiotic start. This is incredibly useful because during that time frame, the clinical picture is often clearer. You're not making your decisions in the middle of the night, and the clinical data is often back that provides more diagnostic information for your decision making. And of note, I want to emphasize that a timeout is not a post-prescriber review that is performed at a monthly meeting. Again, it should occur 48 to 72 hours after an antibiotic start, and a timeout is not a drug holiday. So just so that we're making sure that we all know what we're talking about with a timeout. So let's go to the next slide, please. So here you can see how a timeout fits into your antibiotic stewardship program and how it is an important part of it. So antibiotic stewardship, is the effort to prevent the underuse, misuse, or overuse of antibiotics. And so a timeout can help you in your efforts to improve antibiotic prescribing, so they're only prescribed when needed, and that you can ensure, as we said, those R's, right dose, right drug, right duration, when an antibiotic is needed. And it's all about patient safety. So let's go to the next slide, please. So here's a tool that Telligen and partners in Colorado developed, and it's been very favorably received. We don't just whip out new tools when there's better tools out there, but we were noticing some gaps, and so this tool was developed. It's available on our website for you to download. Everything we provide is at no cost, and we're hoping you'll check it out and let us know about your experience using it. But this tool helps homes to get ready to prepare to hold a timeout. What is your process going to look like? It helps you establish that process and ask questions such as who should participate. Again, the clinical team should include the prescriber whenever possible. If you can move your timeout around so that it can include the prescriber. In a pinch, the medical director can serve as backup. But a timeout is not the same as a nurse huddle. And so that's why it's very important to have the prescriber participate. And the following information should be collected prior to the timeout so that it is available for the discussion. And we've put it in the format of an SBAR. But the information that's going to be vital to your discussion is the name of the antibiotic, the route, the frequency, the reason the antibiotic was started, the culture results, X-ray results, lab results, anything that you have back, and the current condition of the resident. How did they respond to treatment? What is the trend of their vital signs to date? How are they doing? So if we can go to the next slide, please. So now that you've mapped out your process, let's look at these key questions. The purpose of the timeout, again, is to ensure those R's. So for the very first question is based on review of the clinical assessment, laboratory test results, and other diagnostic test results. Does this resident have a bacterial infection that will respond to antibiotics? The goal is to treat bacterial infections, but not colonization and not contamination. So does the clinical evidence support continuing antibiotics? So if the answer to question 1 is yes, we go to question number 2. So if so, is the resident on the most appropriate antibiotic? And we're asking now, is the bug that you're targeting covered by that antibiotic? And again, your antibiogram can be very helpful here. And if it is, can the spectrum of the antibiotic be narrowed? Sometimes we come out with the big guns and broad spectrum, and now your timeout is an opportunity to do what we call de-escalation. So it's a good time also during your timeout to consider maybe what precautions should be in place to protect other residents from this illness, such as contact precautions. So now we move on to question 3. Is the antibiotic being given in a correct dose? Have you addressed optimal dosing, again, considering liver and kidney function? Then we move on to the fourth question. Is the antibiotic being given by the most appropriate route? Did you start out with IV, but maybe can we move to oral now? The next question is, how long will this antibiotic be needed? Can the duration of therapy be shortened? And what do the evidence-based guidelines recommend for this infection? And then question 6, which is often missed on a lot of timeouts, but is the necessary documentation present to support the clinical team's assessment and decisions? Now, you'll notice that for those of you that are using the Agency for Healthcare Research and Quality, or AHRQ's 4 moments of antibiotic decision-making, there is considerable overlap and similarity. If you're using the 4 moments, great, keep using it. I'm always a big advocate of pick a tool and use it. So let's go to the next slide, please. As mentioned by Dr. Mahajan, here is another timeout tool. It is from Nebraska Medicine, and it's available at the link provided here. Again, pick a tool and use it. So next slide, please. So I like to laugh. It's always important to have a little bit of fun. So once you implement your timeouts, you may find that what you learn from them helps drive your next steps for choosing interventions. And I'm going to provide 2 examples in the next few slides of interventions that you may land upon based on the data that you've learned from your timeouts. So you may, in fact, discover opportunities to reduce antibiotic use for asymptomatic bacteriuria. And Dr. Mahajan referred to this. So were the antibiotics started due to the geriatric, oculo, eyes, vesicular, which is the Latin word for urinary bladder, reflex? Instead of seeing the whole person, do those eyes just go right to the bladder, and this patient must have a UTI? And so according to the CDC, antibiotic use for treatment of asymptomatic bacteriuria in nursing home residents does not confer any long-term benefits in preventing a symptomatic urinary tract infection or in improving mortality. And it may actually increase the incidence of adverse drug events and result in subsequent infections with antibiotic-resistant pathogens. So it's very important to remember that. I know sometimes we get a lot of pressure from even family members about starting antibiotics, but for asymptomatic bacteria, the data just does not support it. However, we do know that healthcare providers frequently struggle to differentiate UTI from asymptomatic bacteria, particularly in patients who are presenting with nonspecific symptoms. So data from your timeouts will allow you to examine the ways that laboratory tests are being used. You can look at the rationale for why was the urinalysis or the urine culture sent in the first place. Was it sent for appropriate localizing reasons? And were cultures collected prior to antibiotics being administered? So I hope this little cartoon here is helpful. So let's go to the next slide. So a second example of how timeouts can help you is that we know that antibiotic stewardship includes reviewing use rates of individual antibiotics. And I'm going to focus today on fluoroquinolones. As a result of your timeouts, you may identify specific agents that are driving high overall use. And you may find that there is non-evidence-based use of fluoroquinolones, such as levofloxacin or Levaquin, by your prescribers. And this is concerning your team when you go over the data. I look at that one guy's face in the middle. Look how concerned that dude is. So let's talk about fluoroquinolone. Let's go to the next slide. So here is a list of the complete list of FDA-approved fluoroquinolone antibiotics, in case we're not familiar with the name fluoroquinolone. It's all those drugs that end in floxacin, which includes ciprofloxacin. So let's go to the next slide, please, and you will have a copy of these slides, no worries. So why all the concern about how fluoroquinolones are used? Because there are several FDA warnings of which we should all be aware. And I continually, in my interactions, find that many prescribers are not aware of all of these warnings. In December of 2018, the FDA warned of an increased risk of rupture or tears in the aorta, you know, that really big artery that serves the body, in the aorta with fluoroquinolone antibiotics in certain patients. And those identified at higher risk include the elderly, just a blanket statement, the elderly, those with high blood pressure, certain genetic conditions, and those with other vascular issues. So I bring this to your attention that also the FDA has, continually over the years communicated safety information about other concerns with fluoroquinolones, including significant decreases in blood sugar, certain mental health side effects, disabling side effects of the tendons, muscles, joints, nerves, and central nervous system, and concern that they have restricted use for certain uncomplicated infections. So let's go to the next slide, please. So here's more information about the restricted use for certain uncomplicated infections. Healthcare professionals should not prescribe systemic fluoroquinolones to patients who have other treatment options for acute bacterial sinusitis, acute bacterial exacerbation of chronic bronchitis, and uncomplicated UTIs because the risks outweigh the benefits in these patients. For patients with these conditions, fluoroquinolone should be reserved for those who do not have alternate treatment options. Now, why do we still use fluoroquinolones? Because for some serious bacterial infections, the benefits of fluoroquinolones do outweigh the risks, and it is appropriate for them to remain available as a therapeutic option for those conditions. So if we go to the next slide, please. I've given you a lot of information today. I hope it is useful and practical, but please know that our Telligen team is here to help. And how does Telligen provide support? Our support includes quality improvement expertise, customized one-on-one technical assistance if that's what you need, data and help with interpreting it, innovative tools that I've shown you, and educational opportunities. And we hope you will contact us to learn more. Again, all of this is at no cost. So next slide, please. I want to make sure that you have a tool that you're using for interfacility infection control transfer form. We know that breakdowns in communication are a leading cause of sentinel events. So if you're not already using an infection control transfer form, here's one that you can download from the CDC, and it can facilitate communication about current infections with your partners, such as hospitals and emergency departments. And we hope you'll check it out. So if we go to the next slide. It's just a 2-page form, has lots of good stuff on it. And then last slide, please. Thank you. Thank you for joining. And I hope you'll contact us. I hope you'll all agree with me that Lisa and Nell are the best. And this concludes the talk. And we all thank you for the opportunity to speak with you today. And we have lots of time for Q&A.
Thank you, Dr. LaRocca. That was much more eloquently spoken than my piece. So again, always a pleasure to have you here. I already see some comments here in the chat. So let me just quickly get into our discussion here. So I would again like to start with a comment from Tiffany in here, and before that, just some of the housekeeping questions that came up about whether the slides can be printed, if the presentation will be available, and all of that is yes. By tomorrow afternoon, we will have all the slides presented here available for everybody to download and print, and then the couple of resources that were asked for were already put in the chat box, and now the discussion I want to have is from Tiffany. There was a comment put in that many of our residents present with UTI when cultured time after time. So it almost gives me immense. It is really where this is where we really wish if we could have the person be available for an actual conversation, but I'm going to assume a few things here, and speak to that, and then I'll have Dr. LaRocca also weigh in. So this is really the first question we asked about this question or this comment is that why are we repeatedly culturing somebody, right? So not only as part of your antibiotic stewardship program, you have to review the antibiotics used, but you also have to be very, very diligently looking at all the cultures that have been ordered, right? So I think there was another comment where it says, do you use the definition of infection in CDC or McGear criteria to educate your physicians, right? So I think that's probably is an answer to a comment or question that you had was, is do as an institution you have systems in place where if the urinary tract, if the urinary culture is ordered, are you checking to see if that culture was appropriate? We don't really see any reason why there should be repeat cultures done if there is not an indication. So going back to, so whether it was gyro-oculovascular reflex, where or I sometimes say olfactory, right? It smells bad. And I remember 15, 10, 12 years ago talking about, having asparagus and that causing the smell. So, or we all know the biggest reason why the urine can be cloudy, dark, thick, and smelly is dehydration, not having enough fluids, not per se infection. So, but again, the whole point of doing cultures to confirm the end of infection, it's not recommended. It's actually quite the opposite. So there really, I personally don't, and in guidance too, don't see any reason why repeated cultures should have been done. And if they were done, then why the antibiotics or the diagnosis? So a positive culture is not a UTI. A positive culture is a positive culture. And the question is more towards why the culture was done, not look at the sensitivities and now start putting an aminoglycoside or a lactam antibiotic, even intravenous antibiotic, just because it is a resistant organism, and we see that all the time. So I highly, highly recommend, as one of the comments was, please make sure we use any of the criteria, whether it's a CDC criteria or it's McGear criteria, so Loeb criteria. So anything that's evidence-based that we institute in our practice, either pre-order or post-review, to make a QA, PI, or process improvement for our way of looking at urine cultures and calling them UTIs, and especially repeatedly giving people antibiotics. Dr. LaRocca, you want to comment on that?
Let me see if I can take myself off mute. Yes,
You are. We can hear you.
Okay, perfect. You covered it wonderfully, Raj. I'm also going to put in the comment box some information from the Choosing Wisely campaign. I know that I've heard this a couple times, that you send somebody to the emergency department and they come back on antibiotics for UTI. And then there's a real reticence to stop them because, hey, the emergency room started them. So I'm going to share, and so that those patients, it would be a great opportunity to hold a timeout and again see what the indications were, how the patient's doing, what did the culture show, if that happens to be your particular issue that you're tackling. But there is, as I referenced, I think many of you are familiar with the Choosing Wisely campaign. It was an initiative of the American Board of Internal Medicine, and it specifically has some suggestions for tests and treatment for urinary tract infections in older people, and when you need them and when you don't. And in my experience, it's really important to ask, to really focus on, is it reflexive that we're even sending the urine? Because once it comes back, we feel an obligation to treat it, even if all the indications are that it's colonization or contamination.
Thank you. And I just, I'm just getting, butterflies in my stomach with just listening and hearing and reading these comments. And I want to, just how we said, you empower your nurses, you empower your medical directors, knowledge is power, and folks from CDC who were with us early on have mentioned one of the biggest campaigns right now is the emergency room physicians, emergency room practitioners, and their knowledge of. And we presented this maybe 2 or 3 years ago with our nursing home, for fellows from Loyola, where we did a chart review of nursing home, one of the nursing homes that we are at, folks that went to the acute care setting, and how many of them got a UA and were treated with antibiotic. And after that, we actually reached out to the medical director of the emergency room and did an educational session with them, walked over the evidence-based criteria for nursing home people, where what is the leukocytosis for nursing home is different than, and so all those criteria that have been published, and also what is an infection and UTI versus, what is asymptomatic bacteriuria, and there was immediate effect in the practice in that particular emergency room. And so the fact that knowledge is power, fact that our nursing homes need to have much stronger relationship with our emergency room and hospital, and the fact that we are the specialists in the care of the people we provide, and picking up the phone and having that bi-directional conversation. So as a director of nursing, as admission nurse, as admitting provider, we should have the confidence that we are doing, as long as you have the data to prove that what you're doing is right. First of all, we should have that open line of communication with our emergency room physician. Second of all, yes, if you have a person coming in with a prescription of antibiotic, and if they don't meet the criteria, that's the whole point of doing a timeout. Or it doesn't. The timeout doesn't have to be at 48 hours or at 72 hours, any given time when you have enough data to realize that the antibiotic might be inappropriate, you can stop it. And I can say that. And then again, this is not the same discussion as a course of treatment for established UTI, established pneumonia. That is a different discussion that we're having this morning, where there was a discussion about symptom resolution. Now, this is where we know the definitions of infections. And if somebody does not meet the definition of infection, that antibiotic is inappropriate. And at any given time, the practitioner should be comfortable in discontinuing an antibiotic as long as they have the data to support it. And that is why we're meeting today. That is why all of us want over almost 200 of you here. I'm again blown away with number of people on this call. This is my one. If I tell you one thing, is that whether it's McGear's, if you have a criteria and if it doesn't meet, you you please be empowered to do the right thing. Make sure your clinicians are involved, your medical director is involved, your infection prevention is involved, your attending physicians are involved, and that they all know what the right. And again, that's just UTI. We're talking about skin and soft tissue. We're talking about GI. We're talking about pneumonia and respiratory, and every single thing. There's enough data, the 2012 definition, the surveillance paper from Dr. Stone and her group on defining each and every infection and what are the criteria you need to meet to call it an infection versus, asymptomatic growth of a bacteria. So we have to, and please, I personally, I know Telligen is too, every single person, when you are in that bind, as I mentioned to the person who asked the question about a possibly infected hardware with antibiotics, suppressive therapy for 3 years, a lot of those cases will need case by case discussion and decision, but there is really no evidence anymore to continue a chronic antibiotic suppressive therapy. I know our urologist friends, I know our ortho friends still want not to believe that. Again, but there's enough people, subspecialty, infection control, infectious disease, that will help us. And a lot of those things might be case by case, but as a blanket statement, we can say that chronic antibiotic long-term care, long-term antibiotic therapy is not recommended for most of the things. And so as we are going into to under 4 minutes, let's so again, we will be available for every single antibiotic that was inappropriate stopped appropriately is a win for us, and we take great pride in helping and empowering our nursing home clinicians, especially infection preventionists, who sometimes feel like they don't have anywhere to go. We will be here to help you, case by case, overall education. There's so much information now on the CDC website for you to know, and then again, resources that are out there to make sure that you can have a educated discussion with the hospital providers and your own providers who might be a little resistant to some of these updated guidelines. So and again, Christine, if you have a few comments, I'm going to quickly scan through the comments now. In the meantime, if you want to have anything to add about this, hospitals or other clinicians resistant to shorter duration.
I do, and thank you so much, Raj. And I scanned the comments as well. So here's just a couple of ideas. We're an interconnected world now more than ever, and so I point that out because if there are opportunities, and if Telligen can help you with it, to strengthen the relationships with your hospitals and primary care practices that you share patients with. Oftentimes, a hospital will have resources that the nursing home won't, such as an infectious disease expert. And, it's true, physicians oftentimes gravitate best to some sort of peer-to-peer interaction. So if there is an infectious disease expert at the hospital, and this benefits the hospital, right? Because if they're an accountable care organization model or looking at penalties for readmissions, it benefits them to, rising water raises all ships, to help with maybe some of the challenges you might be having with your prescribers. So I point that out, first of all. It's always critical to have a champion. Is there anyone on your staff, in your medical director, that can be a champion when, say you're having resistance from even holding a timeout? I'm very passionate about timeouts and the opportunity there to improve appropriate prescribing. So I don't know if that's useful, but that might be some of the ways that we start.
Thank you. And as we are just under a minute, we would definitely answer a lot of these questions in the comment box. We might not be able to, but again, this is really where the rubber hits the road, and it's just my pleasure to tell people that no, if you have treated somebody with antibiotic and there are no symptoms, just like C. diff, if the diarrhea is resolved, we don't check for infection of another C. diff to discontinue isolation or determine the amount of therapy. Symptom resolution is the proof of infection being ending, and so no, absolutely not. We do not do repeat cultures. And again, thank you very much. You have our emails. We'll be happy to answer any question. I know this is really, really important. Thank you. And thank you, Christine. Thank you, Telligen. And thank you, Idph.
Thank you, Raj. Thank you, everyone. Take care.
Thank you, everybody, for coming. Please go to your next session. You have to leave this one and then click the other one. And thank you to our presenters.
Thanks. And we'll answer the questions, as said, in anything that's pending in the chat.